So our goals today, I want to provide some definitions, some history for response adaptive randomization. I want to discuss this in the context of multiple design goals. So I want to really kind of harp on this notion of trying to match whatever your design goal is to what your design choices are. And talk about situations. I'm not going to, and never in this talk will I say RAR is good or RAR is bad, but it's going to be an issue of it's well matched for certain things and not well matched for others. The goals that I'm going to mention, they conflict with each other at times. We have finite resources. We have multiple questions. Using our resources on one question may necessarily make it more difficult to answer others. So that's going to be part of this discussion. I want to talk about the multiple design choices that are available in an RAR design. There are a lot of auxiliary choices that matter. So if you have an example and you say, I want to do RAR, that's not one thing. That's almost the equivalent of saying, I want to do statistics. And we know there's multiple ways to make that happen. So I want to talk about, well, what are those choices that are within the RAR that allow this to happen? And I want to pay particular attention to the allocation of control in multiple arm studies, which is going to be a key to a lot of the objections to RAR are really a function of the control allocation. So I want to focus on that and how that can be improved. In the context of that, I'm going to discuss some prior literature and some current examples, and I want to spend a lot of time talking about what generalizes and what does not. I want to be really careful about, I want to avoid situations like, well, this paper said that RAR was biased, and so therefore RAR produces biased estimates. It's certainly true that in some contexts, RAR produces biases. In some contexts, RAR's biases are minimal. In some contexts, the RARs, you get, you can make design changes that minimize the bias. So I want to talk about how the design changes and how those goals, what can be generalized and what doesn't generalize. Okay, so what is RAR? Response Adaptive Randomization. This is usually defined as allocation probabilities for later subjects, depending on responses earlier in the trial. Usually we compute some posterior, it could be a frequentist quantity, but we're going to talk about posterior quantities here. And we're going to allocate based on a function of those. In a two-arm trial, we often allocate based on the probability that the treatment is greater than the control. That's equivalent to the probability that an arm is the best arm in two-arm trial. We can allocate based on that probability itself. So if there's an 80% chance that treatment beats control, we allocate 80% of our subjects to treatment, 20% to control. There's a lot of bells and whistles that can come with this. A lot of times people talk about raising that quantity to a power, perhaps taking the square root, for example. You can truncate it to a range. You can say, I never want to make it too extreme, so I'll truncate it between 20 and 80%. You can also truncate it down, for example. So you could go the opposite direction. If I ever get to 90-10, I'm just going to stop and do 100% on the one that looks better. That function can vary throughout the trial. Common thing to do is if you're using a power to allow that power to increase through the trial. I'm going to collectively call all of these bells and whistles. So I've got an allocation driver, this probability treatment greater than the control, and then I could have different bells and whistles on how I actually translate that to an allocation strategy. That definition is pretty broad. In some sense, everything is response adaptive randomization. That queue of treatment, whatever that function is, if I set up the mapping that I just map it to a constant, I can get a non-adaptive trial. If I raised it to a low power, that often becomes close to a non-adaptive trial. If I'm doing arm dropping, that queue of treatment function, what I'm really doing is truncating some of those down to 0 and equalizing the rest. So whatever my driver function is, I eliminate some arms, those are permanent in this case, and then I equally allocate the remaining arms. So that fulfills the definition. Now, usually all the controversy here is with what we'll call kind of the full, most general version of RAR. And that depends on allocation probabilities that are really varying smoothly in 0, 1. So you can see over the course of the trial, after one interim, an arm's getting 62% of the subjects. After another interim, it goes to 68, then 71, maybe back down to 65, but something where it's varying continuously. Generally speaking, of course, non-adaptive trials are well accepted. Arm dropping, well accepted. The controversy is largely on this more general version. So that's really why we're here. While everything goes under this rubric of RAR, I'm going to focus mostly on, well, do we get a benefit from going to the full version? All right, so what are the components of an RAR design? One of the first things is to know what your goals are. Certainly your design should match. I'm going to spend a lot of time as we go forward enumerating a set of goals. But is it important to treat patients outside the trial well? Am I conducting this study in Alzheimer's because I recognize I'm going to have millions of people with Alzheimer's and I want to make sure those millions of external subjects are treated well? Do I care about treating patients in the trial? We've designed trials for an Ebola outbreak, and we have the notion of the people in the trial, we'd like to save their lives. So that's a goal. We have statistical goals, notions of bias, mean square error, how close are our point estimates. That's potentially part of the goal. So we should know what all these are. Our situation, how many arms? I'm going to make a big deal going forward that the 2-arm setting is qualitatively different than the multiple arm setting. Is there a control? You'll have to make a decision. How do I drive the adaptations? The typical choices here are based on the probability that you're beating a control. So for multiple arms, I could compute the probability that each one of them beats the control and drive the randomization on that. I could also do it on the basis that the probability the arm is the best. Now, those two drivers are the same in a 2-arm trial, but in a multiple arm study, they can be different. If you had a control in multiple arms, if one of the arms is good and one of the arms is fantastic, then the probability you beat control might be high for both of them, suggesting equal kind of randomization. But it also may be true that the fantastic arm is far more likely to be the best, which might suggest more uneven allocation. So those drivers, you have to pick one. An interim schedule. You have to decide when to do this updating. A lot of times there's a discussion of a burn-in at the beginning of the trial. This is particularly relevant when you're not sure of your priors. If you were to do interim analyses with, say, 1 or 2 subjects and start immediately adjusting your allocation probabilities, you need to have a lot of faith in your prior. If you don't, it makes sense to burn in a while and let the data really drive it. You have to decide on all these bells and whistles, powers, truncations, anything to truncate to 0. All of these pieces are part of the process. And at the end, you have to decide what your final analysis is. This may require what I'm going to call a regulatory style win, meaning, do I need to demonstrate superiority with a test that is 2.5% type 1 error controlled? That's a possibility. In other settings, you might find something different. In a dose-finding study, for example, we're trying to find the best dose. We don't necessarily have to have it a claim of superiority on that best dose just to go from phase 2 to phase 3. In the Ebola example that I mentioned, the standard of evidence that allows us to use a treatment more broadly, that may be different than what might fulfill, in an oncology kind of trial because of the severity and the urgency of the need, immediacy of the need. The different design choices that you make, that can have a dramatic impact on the operating characteristics. And some of the choices fulfill some of the goals and not others. So you can find situations where if you do RAR one way, you may treat patients in the trial incredibly well, but you have a very hard time treating an external population. You may lose power. If you make different choices, you may be able to improve the power at the cost of the patients in the trial. And you can quantify those kind of trade-offs. This is related to the ethical aspects of RAR, the altruism of people in the study, for example, the sort of needs of the many versus the needs of the patients in. So you can quantify your design choices to try to optimize whatever your goals are. Again, I want to emphasize results in the literature. We should be careful about overgeneralizing them. Anytime you see a paper, it comes with a particular set of goals and a particular set of auxiliary design choices. And you do have to be careful about which of those generalize and which of those don't. A couple examples here, kind of to formalize what we're doing. A two-arm study, the typical standard RAR design has a control and treatment. We do allocation based on the probability the treatment is beating the control. That potentially allows us to unbalance in favor of the treatment. So we may start off 1-to-1, and by the end of the study, we're allocating 80-20 or 90-10 or even close to 100-0 if you were to allow that. This is an old idea, goes back to Thompson. He actually used the phrase in proportion to. Nowadays we randomize. And certainly you can add bells and whistles, all the powers and truncations. Usually we talk about this in the context of a type 1 error controlled test. But again, I emphasize there are alternatives there. The multiple arm study, a multiple arm RAR, you may have a control, maybe not, and multiple comparison arms. Your design choices here are going to increase. Your control allocation, for example. If you're doing a two-arm study, if you're doing RAR, the only thing you can manipulate is the relative ratio of treatment to control. So if you're increasing or decreasing the treatment arm allocation, you're doing the opposite to the control in order, because they still have to add. So you have to change the control. In multiple arm studies, you don't have to do that. You've got a choice. Do I want to maintain the control allocation to the study? Do I want to decrease it? You actually have the option of increasing the control allocation, which has some advantages as well. Again, in multiple arms, you have to decide what's going to drive the adaptations. You could base it on the probability each treatment beats the control. You can also do it on the basis that each treatment is the best, and those are going to give you different emphasis. And of course, all the same auxiliary choices. When do you perform interims? What are the bells and whistles? What is the final analysis? What do I need to have happen here? It's not written on this page, but certainly one of those choices, am I interested in the best arm only, or am I interested in all the arms? That's going to come up in a minute. In multiple arms, so I'm going to try to make this concrete on how you might do it. This is a standard of Berry Consultants RAR design. We have a control. I'm going to call that arm 0, and 4 active arms. I'm going to burn in 40% of my patients in a 2-to-1 to 1 to 1 to 1 ratio. More controls is going to help me in terms of power. And I'm going to allocate in blocks of size 6. And so those blocks, you can see the 6 rectangles here. 2 of them are going to be control, and 4 of them are going to be active. And I'm going to do this through the entire trial. So in this example, I'm choosing to maintain the control allocation. So at the beginning, in that first 40%, those blocks are 2 controls, and then 1 in arm 1, 1 in arm 2, 1 in arm 3, 1 in arm 4. Later on, I'm still going to have 2 controls, but now I'm going to have 4 active arms, and I'm going to be doing my RAR on those orange active arms. I'm going to base this on the probability that arm J is the best arm. So for arms 1 to 4, and I mean arm J is the best among the active arms. So I could compute those probabilities, and maybe I get a 45% chance arm 1's the best, 30 for arm 2, 20 for arm 3, and 5 for arm 4. I can do some bells and whistles here. I'm going to choose the one, I'm going to truncate any value less than 10% to 0 and renormalize. So if you'll notice here, arm 4, only a 5% chance of being the best. That doesn't seem that exciting. I don't want to just allocate a few subjects to it, and I don't learn a lot, so to speak. So I'm just going to truncate it down to 0. And I'm going to renormalize the rest. So you can see that becomes 47, 32, and 21%, and then 0, I've gotten rid of arm 4. So those probabilities at the bottom, I essentially just make a random draw, and I fill in those 4 active slots. So what can happen is maybe I generate arm 1, arm 2, arm 2, arm 1. I had eliminated arm 4, at least temporarily, and here arm 3 didn't happen to generate anyone. Over the course of the study and repeated blocks, I should see arm 1, arm 2, arm 3 in about the right proportions. Okay, so finishing off the multiple arms, I've got this 40% burn-in. I allocate in blocks of size 6, as I just described. I'm going to evaluate those allocation probabilities every 10% of the subjects. So I do my first interim at 40%. I'm going to do another at 50, at 60, at 70, at 80, at 90. This is part of your design choices to investigate, is it worth doing it more? Does it hurt if you do it less? That would be part of the process. I'm going to do my final analysis. This is a very standard test, but I'm going to base it on the probability that the best arm is greater than the control, and I'm certainly going to type 1 error control that if necessary. There's lots of papers that you can read on this. When the slides are posted, the references will come with it. There's a trial called Race and Sepsis that does this. We've had the Ebola study with the Gates Foundation and Duke. That is published, and a comparative effectiveness trial called ESET, and we'll have those available. So I've talked about a 2-arm design and a multiple-arm design. Are either of these good? And I haven't given you enough information to tell. Maybe yes, maybe no, and that depends on the goals of the trial. Where we're going to head with this is we're going to introduce some goals, and we're going to illustrate that the 2-arm study has some pretty major trade-offs. It does some things well, and it does some things poorly. The multiple arm study is a qualitatively different kind of animal. it is a much more kind of dominance relationship. Compared to a fixed trial, it does extremely well, and we're also going to compare this to arm dropping. And the key aspect of this is, again, our control of allocation is very important in how it works. So what kind of goals might we have? We could have any or all of the following. And I'm going to kind of keep this slide and reuse it and talk about in different studies which goals do we care about. And I'm also going to give kind of report cards on which goals do certain design choices do well. One class of goals is treating patients outside the trial effectively. Power is related to that. If we're in a drug approval kind of setting, if we have a good drug and we can't demonstrate sufficient evidence to get a claim of superiority approval, we can't get our drug to anybody outside our trial. So power is important. We want to choose the best arm. So if we've got 4 arms and arm 4 is the best and we choose arm 3, maybe that has some benefit, but maybe not as much as arm 4. So choosing the best arm is important. We might have a goal that we want to choose all effective arms. And that, maybe we care about the 2nd and 3rd and 4th best arms, maybe we don't. That's part of what to consider. And I've also added this extra goal, maximizing the post-trial rate of success. We've found that often the power and choosing the best arm are a little bit contradictory. If you want to maximize the power, you want more control subjects. If you want to choose the best arm, it might be better to put a few more subjects on the active arm. So we've got a quantity that essentially computes the expected rate of success outside the trial. And so we're going to quantify that as well. Another class of goals is treating the patients inside the trial effectively. I'm going to show dichotomous examples, and the expected number of successes are going to be the metric there. My point estimates for arm effects, I'm going to be interested in bias, variance, mean square error. And again, this is related, do I only care about the best arm or do I care about all arms? And those can be conflicting goals. Making a really accurate statement about the best arm could come at the cost of I can tell you less about the 3rd best arm. In the standard 2-arm regulatory trial, a lot of times our goals, I've kind of grayscaled these. Your goals may differ than mine in any study, and that's part of my point, is it's just worth considering, well, what are they? I want power. I want to be able to get my drug. If I have a successful drug, I want to be able to get it out to the general population. I do care about treating patients inside the trial effectively, but maybe that's a great need. Maybe it's less. If my external population is huge, there's a lot of people out there. I may want to make sure that my power is a bigger goal there because it's the broader population. I care about point estimates for my arm effects. I want to be able to tell people how well something works. In the Ebola study that I mentioned, we have different goals here. I can treat patients outside the trial effectively. I want to pick the best arm. This was not a setting where I necessarily had to worry about power. I'd like to be able to demonstrate a certain level of evidence, but what I really want to do here is make sure that whatever I can get to patients, the best arm is my choice. And so maximizing that post-trial rate of success is key. I also want to treat patients inside the trial effectively, especially if I think I can treat a decent proportion of the outbreak within my trial. There's an outbreak in the Congo right now, for example. I don't have a recent update, but potentially in that setting, you might be able to treat most of the outbreak within a single trial. We've also done some work in antibiotics, And I just want to emphasize this may be a setting where choosing the best arm may not be your only goal. Choosing all effective arms may be an important aspect of it. And the reason is the best arm, after it gets out there, drugs may develop resistance. And having a backup second and third best option, it's important to know what works and what doesn't among all the arms. So all of these trials, we can get different goals. There are a lot of objections to RAR in the literature. There are lots of papers. Peter Thal, Kyle Wathan, Korn and Friedland have a number where they've compared this general form of RAR, so not fixed, not arm dropping, but this more general form to non-adaptive trials. An example here, there's a paper by Thal, Fox, and Wathan in 2015. They discuss a particular two-arm example and evaluate for most of the goals mentioned here. So they have a very thorough investigation of multiple aspects of this. They compared this to a fixed one-to-one design with early stopping. Korn and Friedland have some related papers that make a lot of the same points. If you think about the report card here, those two-arm comparisons, here are the essential conclusions. In terms of power, it doesn't do very well. There's a loss of power. This is intrinsic to a two-arm RAR design. We know one-to-one generates the highest power, assuming equal variances and so on. Maximizing the post-trial rate of success. If we have a study with low power, the external population may never get this drug. So that's a problem. RAR does treat patients inside the trial effectively. You get a higher number of expected number of successes. Also in this paper, the point estimates, there are a number of issues, high variance, biases. There are some imbalances, which I'll talk about in the slide. We look through this. We certainly agree the power goes down. We certainly agree that treating patients inside the trial effectively. We certainly agree with the results in the study that the way RAR is done there, point estimates for the arm effects are bad. And certainly, this is a cautionary tale. You can't just plug in certain kinds of RAR. You can end up in bad places. So the kind of things that are in that paper, they compute bias of point estimates and get that things can be 9% biased. This is on a rate. So we ought to be getting point estimates of a 10% treatment effect. And you can get estimates, 19%. That's off by a lot. 14% of their trials overstated the treatment effect by more than double. And I think that was in a context of there was a 20% treatment effect, and a large number of the trials said it was a 40% treatment effect. Obviously, that's a gross overestimate. And also they noted 14% have a large imbalance in favor of the lower arm. Now, this becomes an interesting aspect. I'm not going to defend the two-arm RAR in this context, but I do want to make this point that some of these results are generalizing. The power for two-arm does always seem to be lower. The issues with the point estimates here seem to be a function of how the RAR is done. And that's important because we don't want to go through and say RAR always produces bias and then say, well, we've got the final conclusion. So for example, we've changed the burn-in of this. We did a burn-in that's much longer. And I think the burn-in in the Thal et al. Paper is very short. We did a longer one. We changed the interim frequency. I think that has less of an effect, but we did do it. And these numbers change dramatically. We still get the lower power. There's no doubt there's lower power, and it's meaningful, and I wouldn't do the two-arm. But the bias itself, 9% goes down to 0.2. The 14% of trials that overstated the treatment effect by double, the 14%, we ran 100,000 simulations, it never happened the entire time. And finally, the 14%, the large imbalance, that does occur, but now you've got 7% in favor of the lower arm, and there was a very high percentage in favor of the better arm. So you still have this, but it is reduced. And at the same time, we do maintain much of the within-trial benefit. Okay, so our comparison here for two arms is that certainly you do lower power. You treat patients better inside the trial, and for the point estimates, this seems to be a function of how you do it. It certainly can be worse, but it can also be fairly neutral. I think I've said that. Let me go through here. In multiple arms, you've got a different story. So I want to talk about, well, why does RAR reduce power? And the reason is we're changing the control allocation. Whenever you lower the control, you're going to lower the power from a 1-to-1. So in a two-arm study, we've got 1-to-1 on the left, control and treatment. We're going to unbalance this, and that necessarily loses power. In multiple arms, you can do better. And I'm going to say what's on that slide. You can think of a standard trial, again on the left, we've got a control and 4 active arms. In a lot of the literature, and there's a recent paper out that talks about the multiple arm setting, in that example, they potentially lower the allocation to control. So you can end up in a situation on the right where the better arms are getting more subjects and the control arm is getting less. And I'm intending the left and the right to have the same number of subjects, but I wasn't particularly good about counting exactly how high all my bars are. This situation, when you lower the control, getting more patients on that best arm and fewer patients on the control arm, the net effect of that can still lower power. And so that's problematic. You don't need to do that. If power is important to you, you can just maintain the control arm. In this case, this is a situation where you'll actually generate more power by doing RAR. You get more subjects on the best arm, and you've got an equal number of subjects on the control. Now again, if interest is centering on the second, third, fourth best arms, you might have more. Here the second best arm does have more, but the third best arm does have less. So that would be situation specific. But that comparison of best arm is actually going to have more power. If you wanted to, you could actually increase the control allocation. So if you really wanted to focus on power, you could use RAR in this context, and you might even do better. We're going to primarily focus on maintaining the control allocation. I'm going to evaluate this in a multiple arm setting. I've got a control and 4 active arms. I'm doing essentially the example that I described earlier. Allocation, blocks of size 6, maintaining control, and so on. I'm going to evaluate this. I've got, assuming a control arm that has a 30% success rate. You can see my 5 scenarios, a null where nothing works. The middle row is a nugget where I've got one arm that hits a 53% rate. I picked 53 to generate a trial that has about 80% power. I've got a mixed scenario which gradually increases, and then I've got these 2 low and 2 high scenarios where a couple arms work to varying degrees. My design goals here, so I ought to be explicit. This is a theme here. I want to be explicit on what I'm trying to do. My main goal is to treat the external population well. So I want to find an arm that's effective, and I want to give this to a broader group of people. I care about power. I want to make sure that I can say, you know, this works. as opposed to, oh, nothing worked, so let's keep doing the standard of care in the broader population. I care about my arm selection. I'm again emphasizing this is a situation where I care about the best arm. I also, you'll see in my slides, I have this thing called IDP. It's defined in the back. I'm not going to spend a lot of time on it. It's essentially, we call it the ideal design percentage. In the absolute best case scenario, going back to the, say, the Nugget scenario, in the best case scenario, you can raise the standard of care from 30%, and you could choose arm 4 and raise it to 53%. So before the trial, people are treated 30% success rate. After the trial, if you do everything perfectly, they're treated at 53%. In practice, that's not attainable. You might not get a success in the trial. You might not get a claim of superiority. In the mixed scenario, you might pick the wrong arm, for example. So essentially, we compute the expected rate that gets to the external population. So maybe sometimes the external population gets treated with a 53% rate, but maybe sometimes it's 47, sometimes it's 41. We compute the expected value. And whatever percentage towards the optimal of 53%, that's what that ideal design percentage is. Our secondary goals. I'm interested in the mean square error of point estimates for the best arm. Again, I'm emphasizing the best arm. So if I tell you at the end of the study, I want you to use arm 3, I think arm 3 has a 50% success rate, then what the mean square error would be is, well, what is the true rate for arm 3? So we'd compare that 50% to whatever the truth is and compute the usual mean square error. I'm also interested in the expected number of successes in the trial. Now, I've picked these goals because, one, I think they're important for a number of settings, pandemics, dose selection, comparative effectiveness. We're interested in the best arm. However, I've also picked these goals because this is a situation where 2-arm did poorly. We knew that power did badly in a 2-arm setting. So I'm trying to emphasize that the multiple arm is a different animal. So that's what again, best arm is important. Some common elements here. My sample size is 240. I'm going to do interims at 96, 120, 144, up to that 240 where my final analysis will be. So this is really every 10% of my data starting at 40%. I have a burn-in, same as before, 2 to 1 to 1 to 1 to 1. Again, this is the example I introduced earlier. I'm maintaining my control rate at 33%. The success criteria. I'm going to, at the end, find the best dose, whichever dose is doing the best, compare it to control, and if that probability exceeds a threshold, then I'm going to make a superiority claim. That will allow my drug to be used in the broader population. I'm going to choose this threshold to maintain a 5% type 1 error rate. You could redo these for a 2.5. The study would have to get bigger. Everything you see here is 100,000 simulations. There's not a lot of sampling simulation error, so to speak. I'm going to compare this to a fixed, a non-adaptive trial, where just all the subjects are allocated 2 to 1 to 1 to 1 to 1 through the whole study. And again, the final analysis is going to be the same. I find the best arm. I try to maintain 5% type 1 error. Let's see, okay. My RAR design. So some key aspects. This is what I told you before, just to repeat. My allocation, 2 of every 6 patients are going to control. I'm doing it in blocks. 4 of every 6 patients are going to the active arms. And I'm driving this on the basis of the probability that each arm is the best. And I'm truncating any of those down to 0. So the discussion that you saw before with the orange rectangles, this is identical. At the final analysis, you can see I've got a threshold here, so I've just filled in what that threshold has to be, found that through simulation. Let me go straight to the results in the interest of time. So this is the comparison, a fixed non-adaptive design to RAR. And these are the results for the mixed scenario. So going back, just to remind you what that is, the mixed scenario starts off at 30, and each of the arms is successively better. Not intended to be a dose arrangement, but I always just tried to, for easy memory, put the higher arms to be better. So for power, the fixed trial gets 71% power. RAR raises that to 81.5. It's meaningfully large better. Well, not large better. Anyway, apologies. It is a lot better. The probability of selecting that best arm goes up. Now remember, arm selection is hard. It's a harder problem than just saying one of the arms works to ask which one is it. So you can see the fixed trial selects the best arm only 48% of the time. RAR raises that to 58. Now both of them, when they miss, they are likely to pick up the second best arm, which is not that much worse. This ideal design percentage, you can see the increase. That's largely a function of the power and the arm selection, just a way of combining it. It's better for RAR. The mean square error for that selected arm. So I'm going to basically, at the end of the trial, say, I think this is the best, and here's how well I think it works. Remember, that's a percentage. So when you square a percentage, you get fairly small numbers. That mean square error goes from 0.0069 for the fixed. It's cut by more than 50%. So RAR down to 0.0033. That's largely a function of the increased sample size. It's also a function of, if anything gets strange, so to speak, RAR has a tendency to say, you know, you're doing well right now. I'm going to give you more subjects and make you prove it. That gives more opportunity to rest to the mean. And then my expected number of successes in the trial. 94 for fixed out of 240 and 98.9, almost 99 for RAR. So you can see that's a relatively small difference. But what I do have here is essentially a dominance relationship. All of these are better for RAR. So one question to ask here is, oh, I always thought RAR was motivated by patients in the trial. Well, why is that only 4.5? It doesn't look that much bigger in a percentage basis. And again, the reason for this is what I set up as my choices. I was emphasizing power. Power requires controls. We established that in 2 arms, so I maintain the control allocation. By doing that, when I forced 1/3 of the patients on the control, I'm guaranteeing 80 patients on the control. I have a 96-patient burn-in, again, intending to make sure that I have adequate data on all the subjects. So by doing that, the theoretical optimum here, given those 2 constraints, would be at the interim, at the first interim, I figure out the best arm with 100% accuracy, which obviously I can't do. At best, that would give me 103 expected number of successes. So our 98 isn't that far from that optimal, and the 94 for fixed just also happens to be good. And again, this is a choice. If my goal was to treat patients in the trial, and that was my primary goal, I wouldn't design it this way. I would have less of a burn-in, and potentially I'd allocate away from the control arm. That would cost me power. So you got to match these up. The Nugget scenario is more extreme. You can see the power. So remember, the Nugget, nothing works except for arm 4, which gets that 53%. Power is up 23%. Probability of selecting the best arm, given that you actually claim superiority in the trial, you almost always do select the best arm. This ideal design percentage, also very high. Mean square error, again, drops in half. And here we get a little bit more of a benefit on the expected successes in the trial. Again, there are so many null arms that getting away from those active null arms is valuable. I'm not going to spend a lot of time on this, but the too low scenario is essentially qualitatively similar. Higher power, 50% reduction in mean square error dominates, and the too high scenario, similar kind of story. So the report card here for multiple arm looks far better. So again, I'm trying to get at this notion of this generalization of, in this two-arm setting, RAR produced a bias. So therefore, I should never do RAR. I know it's bad. Well, that depends. In the multiple arm setting, you've got a lot more levers. You can do this much better. There's not this conflict. By allocating control equally throughout the trial, I've avoided the power ramifications, the power negative. And in fact, I've turned it into a power positive. It's better at choosing the best arm, so that's green. It's better at maximizing the post-trial rate of success. I treat patients inside the trial better. And in fact, I'm obtaining better point estimates because I'm able to get more subjects on the comparison of interest. Now, you'll notice in orange here, this is dependent on my emphasis on choosing the best arm. If my emphasis is on choosing the second or third or fourth best arm as well, I want to know if they work. Potentially those comparisons will suffer. And so we have trials where if we're choosing the best arm, we may emphasize RAR. If you tell us I need to know full answers about every arm, we may be less inclined to do RAR. For this reason, we may get less subjects on the third, fourth best arm. In a dose-finding study, which we do a lot of, there's not much emphasis on, well, do I care about the third or the fourth dose? I want to get some idea of the dose response, but I really want to quantify what's going on the best dose. I want to predict what might happen in phase 3. To this end, this I think hopefully establishes that RAR is far better than a fixed non-adaptive design in this multiple arm setting. There's also a literature that talks about comparing it to arm dropping. A lot of the recent Korn and Friedland work go on to this, and they emphasize an arm dropping comparison as opposed to a fixed design. And part of the reason is they will emphasize comparisons of that second and third and fourth best arm. So this isn't a complete disagreement with that literature. What we are trying to emphasize is that there are situations where RAR does have a clear niche and value. So an arm dropping design. Let's keep the burn-in the same, 2 to 1 to 1 to 1 to 1. I'm going to do interims at 96 every 24 subjects thereafter. I'm going to drop an arm permanently if at the interim the probability treatment beats control is less than 0.6. Remember, with a regulatory kind of goal, we might need this up to 97.5. If somewhere near the trial we're at 0.6, it's a pretty high bar that we're ever going to do better than this. We have changed that 0.6 threshold around and don't get, I mean, we do get quantitatively different, but not qualitatively different results here. At the final analysis, this final analysis is identical to every other trial. We find the best arm, compare it to control, and pick a threshold to maintain 5% type 1 error. We've also found that so we don't want to produce a comparison where we know we can do arm dropping better. This emphasis on the best arm, this comparative effectiveness, pandemic, dose finding, platform trial kind of idea, since our interest is on what is the best arm, it makes sense to drive even the arm dropping on the probability that the arm is the best. So we've gotten better performance out of arm dropping if we do a criteria that's relatively similar to what we did on RAR, although these arm drops are permanent. So you can see here the results. So we've just added, these are the results for the Nugget scenario. One thing to emphasize, if you look at what I'll call the common arm dropping, I think this is what appears in most of the literature, is basing it, drop an arm if it's doing worse than control. This certainly does better than a fixed trial. So you can see the 60% power for fixed. The RAR is at 82% power. That common arm drop is at 75. So it does end up being worse. And again, that's that we're emphasizing the best arm, and arm dropping based on comparisons to control doesn't emphasize the best arm. So it's not well matched for our goals. And I don't want to produce a comparison where I'm not giving what I know is what I think is the best arm dropping. That max arm dropping does do better. So you can see the 74.7% power. Now we're up close to 80. Now it's not as high as the RAR, so that's again 80 versus 82. You can see probability of selecting the best arm, qualitative situations about the same in terms of the ordering. The mean square error is a somewhat interesting column. Actually, the common arm dropping does pretty, it doesn't maintain a lot of the advantage. So for the fixed, you're at 0.0056. RAR cuts that in half. The common arm drop doesn't really get all that close to RAR on here. But doing the arm dropping on the basis of the max does a lot better. So you can certainly see that max-based arm dropping it is worse than RAR, but it's far better than doing what we'll call the common arm dropping scheme. And again, this is entirely an issue of matching design goals to design choices. Here is the mixed scenario. So this is a situation, same kind of qualitative picture. They're a little bit closer here in terms of the RAR versus the two arm dropping designs. But again, for these goals, you get the issue of they are well ordered. So the fixed is clearly the worst, and it's clearly, it's demonstrably worse. You don't want to do this. But any of the adaptive designs, common arm dropping, a little bit better to go to max arm dropping, and a little bit better to go to the RAR in this context. So a summary here. So again, certainly want to match the goals to the design choices. And given how much of there are lots of choices and there are lots of different goals, we need to be really careful about generalizing any paper, and you need to be really careful about generalizing what I just said. I made particular choices and had particular goals and got particular results. So choices like, conclusions like RAR is good, or RAR is biased, or RAR loses power, all of those are, it depends on what the situation is. The auxiliary choices can make large differences. We saw in the two-arm case, for example, the bias disappears if you do RAR a particular way. And of course, if you do RAR a particular way, eliminating the bias, potentially you're not treating patients in the trial as well. It's all the design process to take those trade-offs. And kind of a final conclusion, RAR is doing quite well in this multiple arm, find the best arm problem. So, this is, there's a sweet spot for this where RAR is really tailored for this. And those kind of things, those kind of problems appear in comparative effectiveness. They're essentially the definition of dose finding. A pandemic kind of setting, learning healthcare systems are often interested in finding the best arm. Platform trials are related to this. There's a large class of problems that RAR is well suited for. So I think I will stop there. Tom, I hope I haven't been talking to the air for the last 30 minutes.
You certainly haven't, Kurt. No, we still have a good attendance. I have not yet had anyone post a question, so there's plenty of time for people to type something into the chat and send us a question. And if I can identify you, I could even unmute your line so you can ask supplementary questions. While you're doing that, there's a couple of thoughts, Kurt. So one was something that appears in some of the literature discussing adaptive against fixed designs, or particularly response adaptive randomization. The response adaptive randomization gets criticized for being complex. Could you want to make a comment about that?
So, I think complexity is in the eye of the beholder. I don't know. I'm going to, of course, say I don't consider it complex. Of course, this is something that I do often. In general, we're talking about a relatively simple function of taking the driver, whether it's the probability you're beating the control or the probability that you're the best arm, and essentially mapping that to allocation probabilities. We've written R code to do this, and even with bells and whistles of powers and so on, the actual allocation scheme is 10 lines of R code. So I don't know how complex that can be. I do understand that with some current IVRS kinds of systems, they may just not be set up to do that. That's a relative practical concern, but that's, I think that's implementation rather than intrinsic to the method, and it would be easy enough to get those systems coded to do this, and then that would disappear if that's what the issue is.
Yeah, no, thank you. So I think certainly for me, by far the most intriguing result that you came up with is this marked difference in doing the decision making based on the probability of beating control as compared to doing the decision making on the probability that the arm is the arm with the maximum response. Is that was that a surprise to you, or is that something that you thought was already well known?
So I am sorry, you've cut out just a hair at the beginning of that.
Sorry. One of the most interesting things you highlighted in the talk was the marked difference in making decisions based on the probability that an arm is beating control compared to the probability that the arm is the arm with the maximum response.
Okay, yeah, I think I got the rest of it. Yeah, so I think that is surprising on how big it was. I think it makes some intuitive sense that if your goal is the best arm, being able to really focus on that is valuable. I think it does illuminate why a lot of times in the literature you end up with, oh, arm dropping does exactly as well as RAR, and in other contexts it doesn't. It certainly makes sense that if interest is in all the arms, for example, you would expect the arm dropping to hold its own a little bit better because of those comparisons to the second, third, fourth best arms might be of interest in those settings. Certainly, we spent a lot of time internally trying to compare RAR and arm dropping and fixed designs, and spent a lot of time on it's important not to compare a good RAR to a bad arm drop, for example. And it's important not to do the reverse. So it's important not to compare a fixed trial to a bad RAR. So if anything, one of the lessons was that these auxiliary choices, they matter, and you should have some experience with them.
Thank you, Kurt. I got a question from Gary Rosner. He writes, I know it wasn't part of the objective, but how does the RAR compared to, oh, another comment has just come in and I've lost this, here we go. How does RAR compared to max arm dropping in terms of number of patients treated with ineffective treatment? In other words, did max AD lead to fewer non-responders in your example?
Did treating with AD lead to fewer? So I do have the expected number of successes in the trial. So that's that piece. I'll show it for the Nugget. I don't have the number of patients on each of the arms handy, but certainly I have the simulation results. If you're interested in how many patients were allocated to arm 1, arm 2, arm 3, arm 4, I can certainly obtain that. I think, so just take it as a guess that I've looked at a lot of these but don't recall the exact question, that you get a pretty smooth transition here, that if you're getting more successes in the trial on expectation, on average you're getting fewer patients exposed to bad arms. It's also relevant to consider the variability in that. You know, how often does a trial go completely south? I think that also would be less, but I do need to compute that. That's a good question.
I have another question from Alina Fischer. She says, that was very interesting. Is it possible to get examples of protocols for such trials? And how was RAR written into the protocol? Do we know of any examples?
We certainly have examples. Some of them are behind confidentiality, but I think we can certainly, some of them are public. If that particular person would email me, I'll certainly find something, and we'll see what we can find when we post the slides, which should be shortly. There may be some public protocols that are available as well. I don't recall what's public and what's not, but we do have examples.
It was a good question. Yeah, thank you. An interesting question from Jatan. Oh, hang on. Do the results and conclusions depend on the Bayesian models used to calculate the Pmax? In this, so the Bayesian models, this one's relatively straightforward. Since we have separate arms, we're putting independent priors on each of the arms. The prior tends to wash out once we get to, we're doing our first interim at a sample size of 96. That's enough data that usually the prior has less of an impact. So I do think it's fairly robust. It's a really good question. You can see this. I know Peter Thal and others have noted you can run into problems if you do interims very early and you have particular priors. If the priors are, and they don't even have to be strange, it's just properties of beta priors, they can do weird things on small sample sizes, then I'd be really concerned about making sure that you've thought about the ramifications of that. But by and large, the actual calculation on the burn-in we have, it's fairly robust to the model and priors. I have a question on implementation. Someone, I think it's Peter Jacko, writes, I wonder how RARs are implemented in practice. So you've got a control and 4 active arms, and the physician has just recruited a patient. Does she have to have all 5 drugs in her office, and she just calls the trial statistician to know which drug to apply? And how is the blindness of the physician guaranteed?
So I don't know if this is any different than you would run into in, I mean, if you were randomizing a patient for an arm dropping or a fixed trial. I think you've got the same at some level from the physician standpoint. You know, you should just be able to type this into an IVRS and it pops out, you know, what arm you need to assign to the patient. There are certainly potentially drug supply issues. If you are, so this comes up as a practical matter. If the randomization is going to become really heavily imbalanced, you know, suddenly arm 1 is getting all the active patients, you do potentially have issues with managing drug supply of arm 1. And Tom, you're actually the better person to answer the details of that than I am in terms of how to manage it.
Yes, we have done. We have had some. I mean, sometimes there really isn't a problem at all, and other times you're right. It can be quite challenging, and it also depends on what you're comparing against. If the trial, even if it was fixed, was going to use centralized randomization, then doing dose response adaptive is not much of a to add on top in terms of the randomization. But if the trial was going to use sort of pre-stratified blocks at with a block at each site, so they were just taking the next treatment out of their thing, then of course we have, by requiring central randomization, we have made life a little more complicated. But I think the other thing I remember very early response adaptive trial many years ago. The supply people did fear that, you know, we might give one dose to 90% of the patients, and they had to be reassured with simulations to show that even if one dose did extremely well, it was never going to get more than, say, half the patient allocated to it. So the drug people do need to be included at an early stage in the design, so they understand, you know, how much the supply may need to be biased.
So I think part of this is certainly, in the trials that we've done, we've been able to manage this. You can do supply in advance, and you can also, you know, restock, so to speak, under certain circumstances. If you ended up in a situation where I know I can never have more than X% on a particular arm because it doesn't exist, you know, I know at least one person on the call will smile when I say this. You know, you don't have to let the perfect be the enemy of the good. If you're going to run into that problem and you can't solve it by all the means we've discussed so far, you could cap the randomization and just say I can't go higher than X% because that's what I have available.
Yeah. Yep. We have another question on what's the relationship of strong control versus weak control of the type 1 error for the multiple arm trials and the behavior of the RAR methods? So to define the way we did, so for our simulations, the way I did type 1 error control, I took the null, I did 100,000 simulations, I kind of picked a threshold I thought might be good, and then what I ended up doing is looking at those 100,000 trials, and at that point I see the final posterior probability for all 100,000, I can select the value of the final threshold that generates 5% error.
And so that's how I did the thresholding. And then I waited till I got to that point before I generated all of the others. I think that it's, I could do more. I could do 500,000. I could do so much. Certainly, you're going to do type 1 error by simulation here as the most common aspect, but it's also one that is relatively easy to apply.
And can you comment on the difference between strong and weak control? By preventing any type 1 error in the null case, I guess that's a weak control, and is strong control talking about the selection of non-performing doses in other scenarios?
In this setting, with the arms being independent of each other, if you can control the type 1 error for the joint null, the chance of a type 1 error in the partials, for example, let me find the right spot here. So I think I didn't understand your question at first, but I think I do now. So I think you're interested in the situation where we've got type 1 error control in, say, the joint null, but also worried about situations where, suppose I picked arm 1 in this bottom row where, in fact, it is a null. That's another way to get a type 1 error, so to speak.
Yeah.
In those situations, because I have independent arms in my modeling, the probability of making that kind of type 1 error in, say, the too high or the too low scenario is, if I control it in the joint null, it's automatically going to be controlled in those other ones. Now, that's a consequence of the model that I have. There are other settings, if you're fitting a dose response and various other things, that claim disappears. But here I didn't have to worry about it. The joint null's enough.
So that concludes the questions. I'm just going to open Roger Lewis up. I know he always has something interesting to say on these things, so I think he might talk a little bit about the ethical.
Can you hear me?
Yeah, I can indeed, Roger.
Very good. So the comment I'd make has to do with the connection between the discussion here based on the observed performance of these different design strategies in relationship to a debate that I sometimes hear about the difference between individual ethics and the collective ethics of a clinical trial. And although I'm not sure the terminology is very precise, my impression is that when people talk about individual ethics, they're talking about the degree with which the design choices affects the risk-benefit profile for the individual subject participating in the trial, and that by collective ethics, we mean the overall balance of risk and benefit to the society as a whole, where the risk is borne by the participants, but the benefit may be occurring both in the participants or in those external to the trial. And so the point I'd like to make is that when you hear debates about individual and collective ethics, when you hear individual ethics, you should think about the risk profile to the patient who enrolls at various times in the trial, either before or after some information has accrued that affects the randomization proportions. And for collective ethics, you should think about the degree with which the trial effectively treats not only the patients within the trial, but leads to reliable conclusions that appropriately guides the treatment of subsequent patients and patients outside of the trial. So the operating characteristics that Kert has illustrated through examples here are in fact the answers to the questions about both individual and collective ethics. And the ethics debate is in fact closely tied to and not separate from understanding the statistical characteristics of the strategies and how well they are or are not matched to the particular goals of the trial.
In your discussions with ethics committees, do you find that there's a good understanding of response adaptive designs, or if there isn't, do they sort of get it quite quickly, or is are there people who have a kind of nagging doubt that somehow using a response adaptive design is unethical somehow?
Well, I think this debate and these concerns about ethics and the trade-offs between the various performance characteristics from both patient and societal views is actually a debate that occurs within the clinical trialists and the statistical community. It's not an ethics committee discussion. The ethics committee, or in the U.S. the IRBs, are really focused on the degree with which the participant who's making a decision to participate in the trial understands what the trial will do. And the unfortunate truth is that patients often don't understand even simple one-to-one fixed randomization. And so the idea that they're going to understand these other approaches, it seems unlikely at best. The ethics committees and the IRBs I've been involved with have allowed relatively simple language, simply saying that the chance of being randomized to a treatment can be affected by what's learned early on in the trial. And it's really up to the IRB or the ethics committee to decide whether or not the strategy is acceptable. The majority of these strategies are deployed in a way that improve the risk-benefit profile for patients enrolled later in the trial. So if they believe patients can consent to fixed one-to-one randomization where we purposely refuse to learn from early data, then most think it's okay to allow them to consent to participation in trials with these strategies, even though it's unclear that they understand them any better than they understand the phrase about flipping a coin.
Thank you, Roger. So that appears to bring us to the end of the presentation and questions and responses. Any final closing thoughts, Kert?
I'd just like to thank everybody for attending. I appreciate everyone's time.
Certainly we all do, and I hope you got something from it. So thank you very much, everybody, and have a good rest of the day.